Welcome. Welcome to Move to Learn, the Handspring webinar for manual and movement practitioners. Today is Wednesday, February 23rd, and we are beyond thrilled and delighted to welcome Andrzej Pilat, registered physical therapist and director of the Therapeutic School of Myofascial Therapies in Madrid, Spain. Andrzej is the author of Myofascial Induction, an anatomical approach to the treatment of fascial dysfunction. Volume 1, which we preview today, focuses on the upper body. We are streaming live on YouTube. And before introducing Andrzej, let's take a look at how things will work during this webinar. The webinar will comprise roughly 50 minutes of discussion, presentation, and guided practice, followed by 15 minutes of Q&A. The chat is on, so do say hello and tell us where you are joining from. Please be aware that the presentation includes images and videos of cadaver dissection. We welcome your questions. Please submit these using the Q&A button on your screen. We aim to finish on the hour, but may continue for 10 minutes after the hour to ensure that Andrzej answers as many questions as time allows. We are recording the webinar and will share a link to it in the follow-up email. We are also streaming live on YouTube. And we bring your attention to this disclaimer. This discussion is for informational and illustrative purposes only and is not meant to impart medical or therapeutic advice or instruction. It's my pleasure now to introduce Andrzej Pilat. While I read his introduction, we'll take a brief tour of his gorgeous book. Andrzej Pilat is a physical therapist. Born in Poland, he has practiced across continents, involved in healthcare organizations, university teaching, research, publishing, and private practice. These experiences have led him to an understanding of people's culture, customs, and attitudes towards diseases, stimulating his interest in therapeutic approaches and treatments that adapt effectively to each individual. The last 35 years of his career in manual therapy led Andrzej to focus on fascia, dissecting unembalmed cadavers, and on photography, photographing the beauty of the inner body architecture. Today, Andrzej leads the Myofascial Therapy School, Therapeutic, near Madrid, Spain, where he gives instruction in myofascial induction therapy in collaboration with certified teachers in Spain and worldwide. Although he has published in Spanish, his new book from Handspring Publishing, Myofascial Induction, an anatomical approach to the treatment of fascial dysfunction, is his first book in English. The result of 5 years of intensive research through a vast amount of scientific evidence about fascia's importance to health and illness. Andrzej Pilat, welcome to Move to Learn.
It's the pleasure to meet you here.
And soon we will see you as well as hear you.
Yes. I go to share the now with you. So let me see what happened here. Okay. Elizabeth, thank you very much for the invitation to your excellent channel. And thanks for the Handspring for this beautiful book. So I would like to share with you my experience related to the fascia as a maybe more important structure in our body. And the fascia, in relation to the fascia, we have a lot of new research. So we can relate fascia to the movement. We can relate fascia to the pain. So I would like to talk to you about this experience from a long time, and especially from the experience from the dissection, from the fresh cadavers. This experience was really beautiful. Inside, the body is also beautiful as is the outside. So I would like to share with you this presentation, this experience, and looking to help us to better know what is the disease, what is the dysfunction, and how we can help people in this situation.
Wonderful. I'm so interested to hear how is the myofascial induction technique unique, and how did you come to choose that name?
Yes, this is the long time for looking of different kind of treatment. I'm a physical therapist, so my first view was to typical orthodox physical therapy. Along the life, I was looking to different approaches in treatment.
Andrzej, pardon me, we see the array of your slides, but we don't yet see, here you go.
So to answer to your question, Elizabeth, I would like to take the short definition of what myofascial induction therapy is. It is the method of evaluation global treatment of the fascial system. I'm looking not only to fascia, but fascial system. I think that's very important, that through mostly sustained three-dimensional manual compression, traction at different levels of the construction of the system pursues. Recover and develop the dynamic stability of the fascial system, intensify quality and efficiency of movement, thus optimizing body homeostasis. The term induction refers to the facilitation of the corrective movement and not just to passive stretching of the fascial system. After this definition, I have this question: how are the myofascial induction procedure applied? We have two general parts of treatment. The first part of treatment, there are stroke procedures. The stroke procedure is the treatment that I can apply on the tissue which I can touch directly. For example, here. Or the other question, the other procedure from the stroke procedures. Also, I can treat, for example, the pectoral area. But probably the most important part of myofascial induction is the second form of treat the patient, the sustained procedure. When the movement comes from the patient, what is important in this kind of treatment is the correct touch, and is some induction of the impulse, and the movement comes from the patient. So in this way, I have this short history of the myofascial induction, where we come from. Andrew Taylor Steele, of course, is the pioneer of this knowledge about fascia. Of course, the Ida Rolf with structural integration and Rolfing. Robert Ward, who is in 1960, coined the exact phrase myofascial release. And of course, John Barnes with myofascial release approach, the search for excellence. And also Carol Mannheim, the Myofascial Release Manual, a very important book. Also Luigi, Carla, Antonio Stecco, all family Stecco with fascial manipulation. Tom Meyers with anatomy trains, excellent research in this subject. And also Cantu, Grodin, and Stanbook with myofascial manipulation. I think that we need to tell that, and many others, maybe there are most important person in this journey. So what is the difference between the myofascial induction therapy and the mentioned methods, especially in relation to the myofascial release? In 2017, Leon Chaitov, in his excellent journal Bodywork and Movement Therapies, published the article with this title, What's in a Name, Myofascial Release or Myofascial Induction? And this article, this paper, Chaitov told the question, determined induction relates to the correction of movement facilitation and not a passive stretching of fascial system. This is primarily an educational process in the search for restored optimal homeostatic levels, recovering range of motion, appropriate tension, strength, and coordination. The final aim of the therapeutic process is not establishment of stable hierarchies, but facilitation of optimal and continuous adaptation to environmental demands with maximum efficiency. So, and the second part of this article, Chaitov states, clinicians familiar with myofascial release note that many similarities between it and myofascial induction therapy. With different nuances, they are based on the same concept of clinical reasoning and complement each other. Myofascial induction therapy is characterized as manual tissue remodeling, always avoiding arbitrary stimulus, application altered force, intensity, and direction, focusing on the intrinsic natural response from the tissue. So if I want to resume what is the fascia and what is the myofascial induction, and at the left you have the beautiful picture from the fascia in the subcutaneous level from the cadaver of very fatty person. So the myofascial induction is a hands-on, full body approach focused on restoration of altered function in fascial tissue. It's an evaluation and treatment process in which the practitioner, by applying gentle manual mechanical stress, transfers traction or compression to a targeted dysfunctional tissue, facilitating the recovery. Determined induction relates to the correction of movement facilitation and not only a passive stretching of the fascial system. It's primarily an educational process in the search of restored homeostasis, recovering range of motion, appropriate tension, strength, and also coordination. So if I'm looking to the one of the myofascial procedures, I have these questions. What are we looking for with the myofascial induction approach? And other question, how do we understand fascia? The next one, what are our goals? And finally, what therapeutic model do we use? So I think that this is very relevant, very important information, considering the extensive research of myofascial approach, although it uses the mechanical impulse, rather than looking to fix the body mechanically, create the opportunity to communicate with the person in all its dimensions, physical, cerebral, mental, emotional, and spiritual, and thus facilitating the resources for the healing process by the patient himself. So, what conceptual models of healthcare do we use in the therapeutic process? This is one of the pictures from the book, from the new book, and we are looking here to biological model, as this is the first one. Of course, today is very popular, the second one, the biopsychosocial model. And I think that we need to look to the third one, the enactive model. This concept is based on the experience of a person in the environment. This is the outer circle of this model. The inner circle represents the organism, and the orange one, the orange band, represents the organism nervous system, which is inseparable from changing environment. This is the purple band. So we are looking to the enactive model. This is the model of continuous learning. I think that the treatment to the patient and to the practitioner also is the continuous learning. So the body image, I'm looking for the body image. I'm looking not to take in the patient more movement, more strength, or the level of pain could change. I'm looking on the image. So body image, this should be definition, is a conscious idea or mental representation, an intentional state that one has of one's own body, and includes perception, mental representation, beliefs, and attitudes. This is a citation from the new book. The therapeutic touch can improve the patient's body perception by promoting the reorganization of the body's mental representation, especially for those body regions hidden from vision, such as the spine. So body image and therapeutic touch, this is the tools I use during the treatment. I only perform the treatment with the patient only with my hand. So the touch is so important, and the body image and the touch work together. So if I want to finish this part, how to define the movement? I think that the movement is related with exteroception, primary sense. For example, sound, light, discriminatory touch, also proprioception, sense of movement, body position in space, and finally, it's maybe most important or equally important, interoception, internal senses. So, for example, physiological condition of the body. So I think that this short presentation, I want to answer to your question, Elizabeth.
I'm astounded with the with how you've brought your over 35 years of continuous professional experience, work, and learning, how you've brought this succinctly into an approach that can be a therapeutic approach that can be taught. What is your process of integrating so many different languages? You speak so many languages, you write in a couple of languages, and there's also the language, you've mentioned the language of touch, and then there's a visual language of photography. How have you brought these all together into your approach and into your book?
Excellent question. Thank you very much for that. So let's go with that. This is the start. This is the beginning. I'm Polish, born in Warsaw. I studied physical therapy in this beautiful physical therapy school close to Warsaw during a long time. And
we don't see the beautiful physical therapy school yet. So please resume screen sharing.
Yes, sorry, let me check it. Let me check it.
There you go. Now we're almost there. We're at the array and we just need to go to the beginning.
Yes. Can you see my screen now?
Absolutely.
Thank you very much.
All the participants, you can appreciate that this is a highly choreographed presentation.
So, yes. So we start from here. This is the Warsaw, the center of the old city in Warsaw. I born in this city. And I study, this is the beautiful school of physical therapy. And I have the opportunity to work in this huge hospital. This is the Hospital Institute of Rheumatology in Warsaw. And I meet in this hospital a lot kind of illness, a lot kind of disease, different kind of person with a huge problem with musculoskeletal system, a lot of pain, but the special situation I live here. This is the Surrider Care Home in near Warsaw. When also I work for the long time, and in this place my life changed here. Why my life changed here? I meet my wife in this place. So it was from the first time it was love, and so we moved because of social and political situation in Poland to the other country, and the roadway stopped here in Caracas, this is Venezuela. It's a beautiful country, it's the mountain, El Ávila, and in this city, during my stay in Venezuela for almost 25 years, I had the opportunity to travel and learn from great masters such as Syriacs, Mulligan, Maitland, Chaitov, Kaltenborn, Mackenzie, Ableger, Greenman, Barnes, and also study chiropractic. I approach not very closely, but I approached to the Alexander and Feldenkrais method. I also had the opportunity to practice very shortly in the hospital of traditional Chinese medicine in Beijing. And it was a very important experience. So after that, the observation of the people, of the patients, of the illness, disease in different countries, a different kind of treatment, it's opened my mind to the looking to the situation where this patient is the special person. And we don't have treatment to the illness, to the disease. We should to take treatment to the person. In Caracas, I started teaching physical therapy at the university. This was the first international huge congress relating to the physical therapy and rehabilitation. And in this congress, this is my university, it was almost 17 years that I teaching that. It was excellent experience. And from the first time, I started teaching fascia. Fascia teaching in the postgraduate, undergraduate students, and it was huge experience. The response from person, from patient, and from students was excellent. So I think that in this moment, I need to tell you that the body image, there are different kind of tissues, but our body image and the person in general is also the culture. So the genes and the men, biology and culture. We are not only biology, we are not only culture, we are both. So what are the fruits from this situation? After 25 years in Venezuela, we moved to Europe. And we are living now in this city, the El Escorial, 40 kilometers north from Madrid. This is a beautiful city, along large kind of vegetation. And this is one of the park. It's beautiful to take walk here. This is the school of myofascial induction therapy, to PIMEC. And we teach around the world. This is the group of teachers, certificated teachers. There are about 20 persons. And we teach a different kind of training. The general structural approach, global approach, integrated approach, specialization workshops. This is the basic program, the 3 levels, or 3 years training. And we have about 134 workshops each year. And we cooperate with 35 centers around the world. And the plus minus each year, we have about 1,500 students in myofascial induction therapy. So this is a place when we teach in Europe, and of course, principally in Spain, but also in other countries. There are some pictures from different cities, different kind of students. There are a lot of universities. We participate in master degree with the workshop related to the myofascial induction. It is very interesting experience, not only in the master degree from manual therapy or general physical therapy, but also the special masters, for example, the pelvic floor. We collaborate with 4 or 5 universities exactly in the pelvic floor masters. It's interesting subject. And also in America, in Argentina, Bolivia, Colombia, Guatemala, Ecuador, Mexico, Peru, and also Venezuela. Of course, after COVID, it's very difficult to travel around the world. So we think that the next year we can come back to all these countries. Also Costa Rica. There are some pictures from the students from these cities, and in this way you can observe again different cultures, different faces, and this is exciting. This is exciting how the person in each country, the reaction to the workshop and general reaction to the treatment, because in each workshop there are students and patients. So it's so huge experience to observe the different culture, the different responses, and the different opinion. So from this observation, we have one immediate goals, and the goals is to start teaching in English. This is one of our headquarters, and observe, this is very close to the beach. You can observe from the windows from the school the sea and the beach, and this is our place of working. Also in the night, this is the beach, one of the beaches there. This is the hotel. The students generally spend the time in this hotel. And in 2023, we are starting to train in English in Orihuela de la Costa. It's close to Alicante. In this place, every people speak English. There are more English people from different English-speaking people from different countries, also from England. And Topimet headquarters are 500 meters from the beach. So you can take fun not only during the workshop, but also after hours. The therapeutic process in this place is really important, and I go to present the therapeutic process in the next section.
Andrzej, I have, after the rehearsal with you, I packed my bag for the beach. However, I think that I would be better prepared to really study your book, Volume 1, and eventually Volume 2, before venturing to Spain. So I really look forward to the next section now, when you will give the webinar participants, a view, a window into the therapeutic process with the photography and the videos of the myofascial induction techniques with unembalmed cadavers.
Yes, Elizabeth, you have very good question, very interesting one. Not that easy, but it's the pleasure to share with you. I go to share my desktop again, and we have start perfect with the next observation. Let me see. Here we are. So, what is the therapeutic process? I have some questions here, and maybe the most important one is what or who do we treat? Every time I question myself, do you treat biceps or triceps or other muscle, or you treat the person that probably has some problems over the biceps or with the triceps? So I think that the question is very important. Where you are looking, where you focus your treatment, your session. So I would like to clearly respond to the question, what is pathology? And pathology, for example, may be fibrosis, scar, and this will be the definition: an excessive deposition of fibrous connective tissue, altered architectures, it means structure, and function of tissues. I don't know if we with manual therapy can treat pathology. I think that we don't have a big amount of resources to do it. The medicine, the profession medicine, has a lot of tools to treat the pathology. But I think that we treat dysfunction, and dysfunction is densification. Please look to the picture. This is the collagen. There are collagen fibers in the healthy tissue, and here in the upper part there are densification. How can I define this situation? Dysfunction, in this case densification, increased density of loose connective tissue. The architecture, the structure is generally not altered. There was altered in pathology. The mechanical properties of the fascial tissue are altered, impaired gliding process. And this part, I think, is very important in clinical thinking about the movement and the problem, disability, and so on. This is the seat from Donald Ingber. Remember, Elizabeth, we talked about it. The biotensegrity, the tensegrity model is present here. Donald Ingber observed the architectural model of tensegrity and moved it to the living structure, to the cells. Today, we have a lot of persons who study the biotensegrity model in a different level of construction. And Donald Ingber told a great part of disease are due to the changes in tissue mechanics in response to a fault mechanical impulse. So the movement is held for him. So this is the very difficult question. What model of the body movement do we use with our daily work with the patient? Faced with the scientific evidence, is this model still valid to analyze movement? Again, the definition. This is the definition from APTA, the Association, North American Association of Physical Therapy. And I changed it slightly, but I think this is excellent. Movement involves metabolic changes, structural increases, morphofunctional changes, maturation, physical dimensions, motor, cognitive, psychological, affective, and social activity. So if I think the patient has fault movement, what does it mean? This only problem of the weak muscles, of the joint with inflammation, or the problem maybe is in all of these aspects. So I would like to show you my thinking. So this is the movement from the bones. And I think that we can observe that the movement never is in one plane, in 2 dimensions. The movement all the time is in 3 dimensions. Maybe one of the dimensions is most important, but it's not only this one which I go to check with the movement of my patient. And of course, this kind of movement, this movement is real. But during this movement of bones, you can observe also this movement. This is the back. This is the fresh cadaver without any chemical substance. This is the lumbar point. This is the skin, and this is the superficial fascia. First of all, observe the high hydration of the structure and the gliding movement of the skin with the superficial fascia. Observe here, there are no movement only from the skin or only from the superficial fascia. The superficial fascia and the skin move together. But at the same time, you can observe this movement. Observe the gliding movement between the muscles. And each muscle works in this way. Observe here, latissimus dorsi and serratus, the deltoid and the triceps. If you look at the frontal view, observe what happened inside the pectoral major muscle. Also the gliding movement. What happened with rotation? Again, the gliding movement. And this gliding movement, if I look inside the body, This is the collagen structure from the leg. Observe the gliding movement between the fibers of collagen. And if you go with electronic microscope, you can observe a lot of subjects. What can we see here? We can observe vessels, we have observed cells, we have observed fibers, we can observe also receptors all together, and each of these structures should slide. And the last one, this is the collagen structure. And this is the fibroblast. Fibroblast can the possibility to contract. This is the cells that can contract inside the fascia. And observe, this is natural, this is no imitation, this is the real situation from my electronic microscope. And observe what happened. This is the contraction of myofibroblast, then move all the collagen in this side. So if you look from the first video and to whole video, I can observe at each level of construction of our body, the gliding movement. So one of the definition or conclusion that we have at this time, a body is more than the sum of its parts, and it is so by virtue of the new properties that arise from the relations between parts. This is again the picture from the new book, and I think that we can conclude the specificity of body function comes from the complex integrated functioning of its entirety, and not only of the structural and functional nature of each of the components separately. So the conclusion is we need to see our whole body, not just the one segment. This is the fascia complex. Today we have the definition not only of fascia, but rather the fascial system. This is posterior aspect of the leg. Observe the collagen structures. They share the continuity between all muscles. No, I have not fascia only to one gastrocnemius. The fascia from one, it continues to the other one. So fascial system provides a mechanoreceptive information that there are a lot of receptors inside the fascia. The relationship between its components are more significant than the singular components themselves with their individual properties. The systemic properties are destroyed when the system is divided into isolated elements. Therefore, the complex systems are not fragmentable. Because of that, we need to observe, to treat the whole person, not just the one part. I would like to invite you to observe this dance. Observe the subtle movement of this nice dancer, look of her eyes, how she follows her hands, the exact position of each finger. When I ask, what happened here? What happened in the elbow, for example? So this is the elbow, and this is the movement. So you can tell me, okay, this is the flexion of the forearm over the arm, and we have the movement inside the joint of the elbow. And if I ask you, okay, but where is the essence of this movement? You go to respond me in this muscle. This is the bicep brachii. It contracts. This is the traction from the tendon and the movement of the bones from the forearm. And this is the model that we have in our head. But if you can observe this part, this is the fresh cadaver. This is the upper extremity. This is the window at the level of elbow. And this is the deep fascia. Deep fascia from the arm here, and deep fascia from the forearm. This is lacertus fibrosus. This is bicipital fascia. Observe that it's continuity from this fascia, from the arm to the forearm. And with the contraction from bicep brachii, this is direct communication from fascia to fascia. not only from the tendon to the bone, but directly fascia from fascia. And this is the parallel route of contraction. And I can take problems in the joint with the tendon and the pain, for example. But also, I can take very healthy tendon, no problem in the joint, but the patient has impairment in the movement and also the pain. And this pain can come from this picture. But during this both movement, from the elbow, from the fascia, we need to observe what happened with cells. But because during this movement, we also take this kind of movement. There are movements of the cells inside each one, and also between the cells. So the cells move together. And who is the chief of this, this process? Of course, is our brain. And inside our brain, also we have movement. The movement between neurons and glial cells, and all this movement goes together during the movement of our body. So if I'm looking just to this first picture, and my research, my assessment to the patient stop here, I don't have the whole picture of what is happened here. So one example, this is the forearm, this is the wrist, this is the carpal tunnel. There are the muscle flexor of the fingers. This is excellent dissection. Observe the movement between the tendons. Each tendon can move separately. And I call this kind of dissection the clean one. What does it mean? The fascia is absent. But if you are looking now to the second picture, the fascia is present here. And observe the fascia between the tendons, between the muscle and the tendons, between the tendons, for example, and the neural tract of the vessel or vessels. And this is, the anatomy is called is dirty section, because the fascia is present. So my question is it possible to perform an active and isolated contraction of a single muscle? Forthcoming studies from myofascial therapy may give answers and solutions to many of the human musculoskeletal mysteries or dysfunction. So we can go forward. This is one of our research related to this kind of process of movement between different structures. They move together. This is flexor carpi ulnaris muscle. This is cubital nerve. The flexor digitorum profundus. The person moves the fingers all the time. Extension, flexion, flexion, extension, flexion, extension, and observe that these three structures moves together. So the fascial tissue participate in body movement. It is impossible to take the movement without participation from fascia. We have not the single muscle fibers that fix directly on the bone. We need the fascia, the tendon, the aponeurosis to can perform the movement. So this is the model, the general model that we use for understanding the movement. Intramuscular transmission, myotendinosus pathway. But we have more pathways. We have the intermuscular communication, we have extramuscular communication, and they are called epimuscular pathways. So it's impossible to know the movement, to study the movement in this only form of communication, muscle fiber to tendon, because we have direct communication from muscle fiber to the bone. Please observe now this observation. The next slide is the short cadaver dissection. It's not morbus slide, but maybe too strong for somebody. This is my observation. And I would like to show you that we have absolute continuity of the fascia along whole our body and different level of the construction. This is the back, and after the dissection, of course, it's the 1 day of anatomical work. We put away the skin. This is the superficial fascia. The skin between the lumbar and dorsal lever is continuous. And observe here that the superficial fascia between those levels also is continuous. And if you look to the deep fascia, this is also continuous between dorsal and lumbar part. And there are epimysial and aponeurotic fascia, the muscles fascia. And these fascias, they are not equal in each part of body. This is the fascia from the pectoral part, and this is the fascia, plantar fascia. Observe, there are different structures. So I cannot put the same observation, the same kind of treatment, the same kind of procedure in every part of the body, because the fascia is different in each one. So anatomical links goes from skin to superficial and penetrate to the deep fascia. This is the skin, this is the superficial fascia. Below the skin, the fat. Observe that when the traction of the skin, I can observe the movement of the superficial fascia with the body lobes. This is the pectoral area. This is the superficial fascia. This is the skin. This is the sternal area. And observe when I move the superficial fascia with the fat, the tension is transmitted to the deep fascia. And here, this is the forearm. Observe here the situation. This is the skin. When I move the skin, imagine the scar here, all the movement will be destroyed, absolutely. And finally, the gliding process and the different levels of the movement. Observe the sliding, observe how the fascia move in different levels, and this movement goes all the time together, not only in the superficial, but also the medial, also in the deep layer. So what happens with dysfunction from fascia? We have different processes of interrelation related to the fascial tissue. So the dysfunction can occur, can be present because of the scar. It's of course, it's true. Hypertrophic scar is the limitation of movement, and hypertrophic scar can destroy the movement, but also immunodepression can injure the fascia, diminish essential immune function. Think about the COVID. This is the immunodepression. There are problems because of this kind of inside the connective tissue, inside the fascia, migration of T lymphocyte within the inflamed tissue. Also proliferation, differentiation, polarization, also acidification process, increase of the pH inside the tissue, auto hypomobility or immobilization, release neuronal action, potential decrease of excitation of threshold, and also the aging. Of course, the aging also is the problem. Adaptive plastic changes in cortical structures, and finally kinesiophobia, the fear to move, and dysfunctional motor pattern creation. So in all the process of treatment, we are using two kinds of procedures. Stroke procedure to apply to structure available to direct palpation, and the sustained procedures applied to the deep structure, inaccessible to direct palpation. And the myofascial induction therapy is not only biophysical mechanical stimulation. If you want to observe with me this very simple picture. When I touch the body, I touch the person. So I touch the organism, but also I touch the organ, and also cells, and also genome, and also molecule. So the response from the body comes from here: biochemistry, biochemical changes, signaling, changing at the level of the cell, metabolical changes, physiological changes, and I have feedback with my hand, and I follow up with the treatment. So the fascia behavior is related to the gross anatomy and biomechanics, continuity, gliding and sliding, force transmission, microscopic anatomy and mechanics, matrix, cells, fibers, and of course receptors, and lipogenesis and adipokinase behavior, the immune response. So just few samples. This is the jaw stroke. When you use this application to the superficial layer of fascia, observe this is the superficial fascia at the left. The next one, the transverse stroke. This is the bicep brachii muscles, and I perform the transverse stroke. But look to the picture, to the video from the left. This is the information from the microscopic observation, the picture. And this is the collagen. There are collagen structures, and there are fibroblasts. Observe that because it depends of my movement, my traction, of my stroke, the collagen can change this position. So this is the process which occur inside the body during this application. Longitudinal application. I can perform this application in this situation. This is the scar, for example, inside the body belly, the muscle belly, on inside the tendon or ligament. And this is the sustained procedure. It's slightly different. Observe I apply only very small force, and after that, the movement goes from the patient body. But this is not the active movement from the patient. This is automatic movement. This is the correctional movement. And we are looking in myofascial induction with this kind of response from the patient. So this is the last slide. I can perform different kind of application. I can perform the stroke, the sustained procedures. When I put my hand over the skin, I should to know what happened inside the body, not only in the outside, not only on the superficial layer, but what happened in the deep layer. In this situation, myofascial induction therapy, fascia and therapeutic movements come together in this situation. So it was the last slide from this presentation, Elizabeth.
Marvelous, Andrzej. And no surprise to you, we have a question that follows perfectly from your lecture and from your video. Barry Craig, who joins from Washington State in the US, writes, in addition to changes in remodeling the structure of the fascial tissues during the therapeutic process, what changes do you think are happening in the fluid shear stresses and composition of these fluids under the influence of myofascial induction work?
Yes, in our teaching program, one of the workshops in the third level, the last one of the workshop goes to the liquid, to the all kind of circulation. So we go to the veins, to the artery, to the lymphatic system, because I think that the most important process that occurred during myofascial induction, there are changes in this level, in microscopic level, the movement between liquid, between the cells, probably also inside the cells. So this kind of changes they are normal during this kind of treatment. So I can observe in the patient different responses. For example, I can observe the change in the blood pressure, the heart rate, the temperature, and so on, so on, so on. But if you look to the inside to the body, there are also changes in the brain decision. The cortical level also responds.
The amount of detail is overwhelming, and I know that you've devoted over 35 years of continuous professional focus to bring it to this book. What are your recommendations for those of us who look forward to studying your book? What is the best approach for a movement educator, say, to use your book as a reference and a study guide?
Yes, I told you we have headquarters in a lot of countries, but I think in relation to COVID, now we have this excellent communication online. So after the presentation of the book, we have a lot proposals to participate in different conferences, congresses, and so on. And the next one, very important, will be the British Fascia Symposium. The participation in this British Fascia Symposium will be with different subject. So if you want to follow me, observe our information in the Instagram in Tupimec, and Handspring also all the time has the notice from us, and we can share this information with you.
Wonderful. I know that you've prepared a very extensive video tour of the book, both in Spanish and in English. Would you talk about that video tour that you've created for each chapter?
First of all, the book is beautiful. Not because this is my book, but because the Handspring put all the force, cooperation during the 5 years. We had, and the last month, I took more communication by email, WhatsApp, and so on with Handspring, and more than with all my family. So the Handspring now is my family. I think that this huge book needs to presentation. So we prepare the video. It's about 50 minutes. Is the journey along the book. So it's almost ready. You're right. It's in Spanish and in English. And I would like the cooperation from Handspring to put this video in the YouTube channel from Handspring. And in this each chapter, I take the possibility to have time to more explication. What is the contents of each chapter? So I think it's very interesting. You are welcome.
Yes. And Andrzej, speaking as a movement educator, I have never done any in-depth study in manual therapy. What are your recommendations for how movement practitioners can use your book as a guide to improve our work with our clients?
Again, difficult question, Elizabeth. But
you're welcome again.
I think that during the treatment with the movement or with the hand, the response from the body is the same. What are you looking for during the movement education? You are looking not only for the force, not only for the joint amplitude. You are looking for the coordination. This is the most important. If I want to move freely, it's not enough to take excellent muscles or flexibility in the joint. If my brain cannot communicate with each part of my body, coordinate this movement, the movement will be fault. So I think because of that, in the first answer to your first question, it was this slide. The movement is related to the exteroception, proprioception, and interoception. So I can move the tissue with my hand. And you, as expert from this, you can give to the patient the instruction how to move, but himself, without touching. And probably result will be the same. Because of that, I think the discussion, what the technique is better, it's a stupid question. Because we can act with the patient from different viewpoints. And in each situation, the result could be excellent.
Thank you very much for that thoughtful and optimistic answer. Very encouraging.
And I think one question more. If you are moving the patient with the exercises, and you are moving the elbow area, it's important to you to know what's happened between arm and forearm. This position, the hand is okay, or this one is better. And what happened with fascia here? If you put this movement, the limitation of the elbow is present, but in this one, no. I have the injury of my shoulder, and take the supination movement in position of the flexion of the elbow to 90 degrees. And I go to move my fingers up to you, to the screen. Can you observe what happened here? So you, as the movement teacher, you need to know what happened with my body. At what level? Know each movement exercises that you are performing to the patient work in this same level of construction of the body. Maybe one of the movement focus just to the superficial layer, or maybe other to the joint. So in this treatment, after reading the book, you can take this information for you.
I'm going to be busy these next months. I can just tell.
Good luck.
Thank you. Let's take a look at the slide Handspring has prepared for your generous discount on the book. I'll just get my questions out of the way here. Yes. So Hillary, in order to draw people's attention to the slide, this is what I need. Yes. So Handspring is offering a generous discount code to get 20% off this gorgeous book. And this discount code will expire on March 31st. You can also see on this screen how you can get more information from Andrzej Pilat, from the Tupimec.com website, the social media handles, and also for more information on the Handspring Publishing YouTube channel. You can see that you use the code MTL, that's Move to Learn 2520, at checkout from handspringpublishing.com. And Andrzej also mentioned that he will be presenting at the British Fascia Symposium that will be in May of 2022 this year. And when you go to his social media accounts, you can find out the numerous podcasts he's doing on his virtual book tour. So let's return to Andrzej to ask just a few more questions and discuss here. For someone who is who's already a manual therapy professional, what is your advice? What is your guidance to a dedicated manual therapist in order to improve the excellence, the quality of their interaction with their clients and patients?
I think that the most important form of healing is the hand, is the touch. Why? In November last year, the Nobel Prize from medicine was to discovered of piezo. Piezo, there are some enzymes there are in the over the cell, and this kind of enzyme communicate all organs of our body, our brain with our knee, and respond to very soft touch on the skin all the long time. So they are not injection, prostheses, pills to obtain the same result. So I think that the hand, the touch, probably is most important. When the small child fall down, and he cry, and the mother put the hand. No, it's not only love between both. This is the treatment, scientific treatment. The Merkel receptors detect this touch and put it in the circulation in the whole body, especially to our brain. The glial cells respond to this kind of movement. So I think that healing the patient with the touch is only part of movement. Because of that, I think, again, that what you can do with exercises of any other form of movement is possible to obtain with the touch, and with the touch is possible to obtain what you can obtain with the movement.
On this inspiring message and note, shall we bring this particular webinar to a close? Do you have closing comments before we look at the next event? Andrzej, thank you very, very much for sharing your wisdom and the fruits of your transcontinental explorations through your life. Right.
I would like to touch you over the screen. Thank you very much. Thanks for all to listening us, and Elizabeth, excellent podcast. You are realmente the star of this. Thank you very much.
I'm grateful. Let's take a look now at the slide that tells you who we meet next month. And on March 23rd, we are just delighted to meet Karen Kirkness, the author of Spiral Bound, Integrated Anatomy for Yoga. Karen Kirkness weaves together threads of development to see how our morphological constraints arise in the earliest moments of life, and how this rotation lays the spiral groundwork for rotational kinematics that encompass all tissues. So in preparation for Karen's presentation of her book, make sure that you go to the Handspring website for your discount code on Andrzej's Volume 1, so you can study up and then be prepared for the next excellence from Handspring Move to Learn. Thank you all.